So we're here to just have a discussion and demonstrate some options for treating the knee in seated. And obviously we're working on the knee, but because of where we are, we could also work on the ankle, but we'll mainly focus on the knee. So the idea here is that we need to invoke a few of the concepts that we've talked about over time. So one is patient positioning. So the patient is in seated, which means that we need to consider less stable means I need to make the patient more stable. Now in this case, because we're going to be working on the leg, the patient's going to be fairly stable, or really the knee. The patient's going to be fairly stable because they're sitting upright, they're in control. Contact as control does come into play because the leg is essentially free, and because the leg isn't going to be supported by the table, I'm going to need to control it. So with the knee here, if we have reason to believe that we should look at the knee, the patient's probably reported it, we may have picked it up in another part of our scan, or the patient's in quite a bit of pain, so we kind of just go straight to the knee. So the patient's sitting as comfortably as they can be, and what I can do is just lift your leg. I basically come here, right? So now the concept of contact as control, we've got that. So I've got good contact with both legs, patient's safe. You see how the patient automatically just put his hands back to brace himself. That's really not an issue. That's probably a good thing. Let the patient feel safe. So you'll see that automatically I'm able to control the knee on some level, create some minor flexion extension just by moving my legs. That is because of where my legs are placed, or my thighs are placed in relation to the patient's legs, so lower limb below the knee, and also because I've got that contact, right? Now, with our options, if we wanted to work on the soft tissue surrounding the knee, we want to be able to work perpendicular to fiber direction. So if we're thinking about the quadriceps, right, we can lift, so we want to generally shorten the tissue that we're going to work on. We lift the foot a little bit to take a little bit more tension out of, or to shorten the quadriceps region, and then I can push and pull, right? So I can work on the quadriceps tissue here. I can keep the quadriceps tissue relatively steady on bind or on ease, whatever I need to do, but probably on bind, and then I can move the bone in relation to the relatively still quadriceps tissue. I can work on the hamstring tissue here, so what I want to do is drop the foot a little bit, and then I can pull, push, I can do that there, and then I can hold and move the thigh in relation to the relatively still hamstring. I can work on the calves, right? So with respect to the knee, I may be considering the gastroc. So for me to have space to do it, I'm going to drop this knee out, right? So we've still got good control, but I can work on the gastroc here as well. So push and pull. The tibialis anterior, or the muscles of the lateral compartment of the thigh, or the leg or shin, are here, so I can work perpendicular to fiber direction. You can't see it, but I've got my hand essentially like this, pushing and pulling against that musculature. I can work against the patella, or I can glide the patella to check how it's doing. So if you have reason to have concern about the patella, you would want to more or less straighten the knee all the way out so you can get the tissue out, or the tension out of the quadricep, and you can do your patellar glides, right? You can do that there. As far as the knee itself, you can start to have a very good idea of what's going on with it by having a good broad hold, so broad contact for multi-point discrimination, and you can use your legs to mobilize the knee to kind of get an idea of what's going on. It's hard to see from here, but the fibular head is available to you, right? So what we'll do is we'll just say here, this is going to look different, but the fibular head is here. I can identify it, and I can create glides on it, right? So it would look something like that on this side. And then what I've got the opportunity to do from here, right, if I want to traction against the knee, depending on what I need to do, I can alter the position of the leg in relation to the thigh, and I can create traction, so I can create the traction. Or what I can do is I can have the patient just lean back a bit, right? That will build some traction in and come back, right? If I need to create compression, I can create compression. If I need to create torsion, I can stabilize the thigh, and I can move the leg in relation to the thigh, right? I can do that. If If I need to start to combine them for some reason, such as compression and torsion, I can do so. So I just want to display a lot of these options, but we're guided by all of the same principles. So soft tissues working perpendicular to fiber direction, contact is control, so good contact, and the ability to mobilize the leg in relation to a relatively still thigh. The patient, as far as patient positioning, the patient needs to be kept stable because they're in a relatively unstable position, upright, in a seated position rather. So there's less of them in contact with the table, but the patient will often take care of that by themselves by just putting their hands down. If they feel safe, they'll probably leave them up. Either way, it's not necessarily a big issue because of what we're working on. And then we've got relational motion again. So the thigh is going to be the thing that's relatively still in most cases when I'm looking at the knee. And I can mobilize the leg in relation to the thigh in whatever way is necessary. I've got good contact, I've got good control. So all of these concepts come into play for the possibility of you to work on the knee in a seated position, right? So again, traction, compression, torsion, right, in whatever order that I would need to. When you're considering your activating forces, you want to be organized, and we've talked about that before as well. So just an overview, and so overview as far as discussion and visual representation of what it might look like treating a knee in a seated position.